and I'd like to present Dr. Sawsan Nowilaty. She's very well known in the country, and in the specialty. She's a senior academic consultant here in the Vitreoretinal Division at King Khalid Eye Specialist Hospital. She obtained her doctorate degree in medicine from the Faculty of Medicine in Tunisia. So she has held multiple positions here in the hospital, like Associate Chief of the Vitreoretinal Division, Director of Medical Education on a few occasions, and she's also organized the annual Ophthalmology Symposium in many of its editions. She's an accomplished researcher, as we all know, and her publications include 2 theses and over 52 peer-reviewed publications in index journals. She has delivered an uncountable amount of scientific presentations, both locally and internationally. And her major research interests include diabetic retinopathy, macular telangiectasia, posterior microphthalmos, and hereditary retinal degenerations, which are things we're going to be talking about today, I believe. She's a member of the Saudi Ophthalmology Society, the American Academy of Ophthalmology, ARVO, and I believe she was recently granted a fellowship of the American Society of Retina Specialists as well. But perhaps she is best known for her invaluable contribution as a full-time teacher here in the hospital to the ophthalmology residents and fellows, and for providing mentorship and supervision for all her activities. So it's an honor today for me to introduce her, and her lecture is titled, "Is this macular edema a case-based discussion?" So I'll leave the floor open for you.
Thank you very, very much, Dr. Semide. I'm humbled by this introduction, honestly. I thank you very much, and I hope that this presentation will be useful to the audience. I'm going to share my screen now, and please let me know if things work on your end. So can you see the slideshow now?
Yes, perfect.
Okay, all right, very well. So as Dr. Semide said, the title of this lecture is this macular edema? Are anti-VEGF injections appropriate? And we're going to do this review of seeing several cases. In the past 20 years, optical coherence tomography has become indispensable for the diagnosis of macular edema and different macular pathologies, and understanding the anatomic changes that are involved in these pathologies. And in parallel, intravitreal anti-VEGF injections and corticosteroid injections have also become the mainstay of treatment of macular edema, and changing the paradigm completely from laser to injections. And with this, we have seen an explosive use of intravitreal anti-VEGF therapy, both by retina specialists, but also by other ophthalmologists, even general ophthalmologists that rely in their indications primarily on OCT. However, when OCT is misinterpreted or misused, it can lead the non-retina specialist or the hurried and non-diligent ophthalmologist, or even the ill-informed retinal specialist, to consider macular changes seen on OCT as macular edema and proceed erroneously with invasive intravitreal anti-VEGF therapy. So the purpose of my presentation today is to show you, by using actual cases, how to differentiate macular edema from conditions that may suggest macular edema, but which are not macular edema, and which anti-VEGF treatment is inappropriate. So before we do this, let's briefly recall the OCT features of a normal macula. We all know that the macula is the retina is a multilaminated structure, and on a macular OCT, we see this lamination very beautifully, and the retina, as the retina sits nicely on the retinal pigment epithelium, beneath it is the choroid, and beneath that is the sclera, which you can recognize by being avascular and very smooth in the reflectivity. On top of the retina is the vitreous, which is hyporeflective, looking very dark. Now, we usually refer to the retina as inner retina, primarily irrigated and perfused by the retinal vessels, and the outer retina, which is perfused by the choriocapillaries. And when we juxtapose, overlay a histologic slide, we can see how beautifully the OCT demonstrates the neat structures of the retinal tissues. We will start by looking at the inner retina, and we go from inner to outer. We will start with the nerve fiber layer, and the nerve fiber layer is hyperreflective. Actually, all fiber layers are hyperreflective, and all nuclear layers are hyporeflective, and this is important to know. So we will start with the nerve fiber layer being hyperreflective structure, followed by the ganglion cell layer that harbors the nuclei of the ganglion cells, followed by the inner plexiform layer, which is a hyperreflective layer since it's a fiber layer, and then followed by the inner nuclear layer, which harbors all the nuclei of the cells present in the retina, with the exception of the photoreceptors and the ganglion cells. This is followed by the outer plexiform layer, a hyperreflective layer, as we can see here, which connects the photoreceptors axons with the dendrites of the bipolar cells, the horizontal cells, and so forth. So this is a true plexiform layer. In the outer retina, we have the Henle fiber layer, and the Henle fiber layer is composed primarily of the photoreceptors axons as they insert into the plexiform layer, and this layer is extremely important for the diagnosis of macular edema. This is where fluid accumulates primarily. This is followed by the outer nuclear layer, which is hyporeflective, it's made up of the photoreceptors nuclei. And then you've got the external limiting membrane. These are the outer retinal bands, which we all know, external limiting membrane. And then we've got a hyporeflective area, which is called the mild zone, which we don't speak much about. And then there is the EZ, the ellipsoid zone, which is considered the zone where all the mitochondria are stacked in the inner segment of the outer of the photoreceptor. This is the photoreceptor tips here, that's where they're located. This is the interdigitation zone where the photoreceptors interdigitate with the apical portions and the velocities of the retinal pigment epithelium. And then at the bottom, you have the Brooks membrane and the RPE. Now, the Henle fiber layer, as I said, is very important, the diagnosis of macular edema. As you can see, it is hyporeflective, and it is usually, it's right there, you can see it right there, very practically merging with the outer nuclear layer. Both of these are hyporeflective, and this is when the OCT picture is taken en face and straight on. So here it is again. So the reflectivity, however, will vary if the OCT image is taken a little bit tangentially. So you may see it a little bit more hyperreflective. This nerve fiber layer may be hyperreflective here within the nuclear layer. But in standard OCT, it is hyporeflective as part of the outer nuclear band right there. And I need to remind you that this elevation here is not fluid under the ellipsoid zone, but it's actually a normal feature of the focal cone, and it's called the clivus inversus. A very brief note about how we do acquire an OCT. Well, we generally do a horizontal line scan passing through the area of fixation. And this is usually taken repeatedly, so it creates a very high resolution scan. Same thing, we do it vertically as well. And then we do a raster scan, which permits us to make up maps that analyze the thickness and volume of the macula. And if you want to center our focus on a specific area, we can do a radial scan that goes through the entirety of that specific focus right there. And the results are displayed either as line scans or, as you know, as maps, the EDTRS colored maps, which can detect the thicknesses and the volumes of the structures that are within this map. And OCT, because of this, can precisely locate the macular edema with regard to the fovea, either showing an extra macular thickening, which we often call center involving macular edema, or a diffuse macular thickening, or even just a centrally located macular thickening, which we call center involving macular edema. But of course, we don't really rely on maps to diagnose macular edema. We need to diagnose it based on an accurate interpretation of the OCT. And this relies, of course, on knowing the anatomy, which we just discussed, the retinal and the choroidal anatomy, and their normal reflectivity and how they deviate from normal. For example, high reflective tissues are, for instance, the RPE layer. This is the most reflective, highly reflective part of the OCT. A moderate reflectivity, as we see in the plexiform layers, for example, lower reflectivity, such as we see in the nuclear layers, and a very low reflectivity, such as we see in the vitreous. And any change in these retinal reflectivity indicates that the structures are either damaged or misaligned. And now let's define what is macular edema. Well, in simple terms, macular edema is a collection of fluid that causes retinal thickening. And this collection happens inside the retina in specific layers, and particularly the Henle fiber layer, or at least that's where it should start. So it can be caused by extravasation of fluid from normal macular vessels that have now, because of pathology, have become impermeable, such as we see here, for instance, in a vein occlusion, where the vessels all leak because they're subjected to certain ischemia and poor perfusion, or as we see, for instance, in certain inflammations where the capillaries just become, they're normally impermeable and now they're permeable, and therefore they leak, for instance, as you can see here in this cystoid macular edema following cataract surgery. Extravasation can come from abnormal retinal vessels, such as, for instance, microaneurysms in diabetic retinopathy, or telangiectatic vessels, due to several pathologies, including vein occlusions and retinal telangiectasia. And sometimes extravasation can come from extramacular telangiectasia or aneurysms, where the fluid gravitates towards the macula. Sometimes macular edema is a passive consequence of excessive subretinal fluid that the RPE cannot handle. For instance, if you have a very chronic central serous chorioretinopathy with subretinal fluid, sometimes the RPE gets so tired that actually the fluid migrates inside the retina and causes, in addition, cystoid changes in the retina. And the macular edema will present in different ways on the OCT. Generally, it's an area of thickening with a fluid collection. And as you can see here, the fluid is located primarily in the Henle fiber layer and in the outer plexiform layer. This is very important to recognize, okay? The fluid can be more massive, causing a spongiform or a sponge-like thickening of the macula. But again, the fluid is primarily located in the Henle fiber layer and the outer plexiform layer. It is important just to follow where the location, where the fluid comes out from. For instance, here it kind of abuts at this hyperreflective area, showing that the fluid actually comes from the lower portion here, which is the Henle fiber layer. Okay, and I'm showing you here examples of very marked macular edema, but where most of the fluid is located in the Henle fiber layer. The fluid can collect in cystoid spaces, again, as we can see here. Again, this is in the Henle fiber layer, all right? And it can be associated sometimes with internuclear cysts, such as here, causing aschises, splitting in the internuclear layer, in addition to the nerve fiber, to the Henle fiber layer edema, as we can see here. Recognize always that the fluid in the outer plexiform is more than the fluid in the inner nuclear layer. This is very important. Sometimes macular edema is associated with subretinal fluid, and this may be very difficult to detect clinically, but you can see it on the OCT very nicely. And again, here the nerve fiber layer, the outer plexiform and the Henle fiber layer fluid is more than subretinal fluid, and so is it in this case. You can see that massive edema here, but there's subretinal fluid, but this is less than what is expected here. Of course, macular edema can also be associated with tractional elements such as vitreomacular traction, epiretinal membranes, or even hyperreflective foci, as we can see here in cases of inflammation or diabetic retinopathy with presence of lots of exudates. And of course, you all know this, that if you have macular edema, you should have leakage on and pooling on the fluorescein angiogram. So now let's look at cases where macular edema was either correctly or incorrectly diagnosed. We'll start with case number 1. This is a 29-year-old female. She was referred to us for cystoid macular edema in both eyes. She's had poor vision since the age of 12, but she has no night blindness and no photophobia. She's had surgery for chronic angle closure glaucoma, and her parents are second-degree cousins, and there's a very high glaucoma history in the family, but there are no known retinal problems. Her visual acuity was quite poor in both eyes, and she had clear corneas and rather shallow ACs with the glaucoma touching the lens and the iris, and she had clear lenses. On a fundus examination of the right eye, you can see that she has got advanced optic nerve head cupping. She has a flat retina, perhaps some RPE changes, and a cystoid maculopathy, which I tried to enlarge for you right here. You can see the cystoid pattern. In the left eye, very, very similar features, optic nerve head cupping and a flat retina with a cystoid maculopathy. When we did an OCT, we looked at it, and what she had here was primarily inner nuclear cysts. Of course, you can see this cystoid marked cystoid change, and on a cursory view, you would think that this is macular edema. But when you look carefully, the cysts start in the inner nuclear layer, okay, and they are quite large here. So, but I don't know if you can see something else. Do you notice anything else? I want you to take a moment just to look at the OCT here and see whether you can, among yourself, decide whether there's another feature that was recognized on this OCT. Here's that same eye, okay, and a little bit the scans here are taken a little bit, above and below the fixation point. And again, you'll see that this is mostly ascites with inner nuclear cyst rather than fluid accumulating in the outer plexiform layer. And the schisis was actually apparent even far away from the center, okay? So again, there is no real collection of fluid in the outer plexiform layer. And again, I'm asking you if you can see anything else right here. Take a moment to look at this. And now we're gonna look at the left eye because I think the left eye will be more apparent. Same feature with the schisis and inner nuclear cysts that are away from the center of this maculopathy, and yet if you notice anything else, you'll notice that there is diffuse retinal separation throughout the macula. There is actually subretinal fluid with shaggy photoreceptors, these elongated photoreceptor outer segments. It seems like the retina is floating on top of the RPE and not really interdigitating with the RPE as it should be. When we did a fluorescein angiogram, there was no leakage, both in the right eye or in the late frames of the left eye, no leakage whatsoever. So that put the diagnosis of macular edema into question. Now, the physician who referred it for the treatment of macular edema, thinking that the macular edema was due to the tube irritating the iris. But is this a correct diagnosis, and do we need more tests? Well, we did an autofluorescence, and this gave us the clue. There's abnormal hyper-autofluorescence throughout the periphery, around the macula, nasally, with large patches of hypofluorescences, again, around the macular circumference and centrally. And this gave us the clue. I'm not gonna divulge what it is right now. We're gonna look at the few more cases, and you'll see, what this represents. Fortunately, we did recognize the diagnosis, and we did not give any intravitreal injections of anti-VEGF. Here's a 4-year-old boy. He was referred for VKH. He has had poor vision in the right eye for God knows when, and he's had an isodeviation in the right eye. His visual acuity in the right eye was 20/100 and 20/60 with a hyperopic correction. He had normal IOPs and had normal anterior segment examination. The fluorescein angiogram shows that there was this increased hyperfluorescence around the macula and even nasally. And there was a suggestion of perhaps a choroidal neovascular membrane or a fibrosis. On the fundus picture, you can see that there are multiple yellow lesions in the fundus, giving the impression that this is a choroidal inflammation. And when we did the OCT, we noted that there was subretinal fluid indeed, and cysts both in the inner nuclear layer and in the outer plexiform layer. So there was some macular edema, of course, and there was this hyperreflective spot that corresponded to the fibrosis or the inactive choroidal neovascularization in here. But if you notice that on the fluorescein angiogram, the rest of the macula does not really leak in the late phases, nor does the optic nerve head leak, which is what we expect in a VKH. The left eye examination had very similar features. There was a faint hyperfluorescence throughout the entire macula and nasally, but there was no leakage. There was no optic nerve hyperfluorescence. And if you looked at the OCT, there was a diffuse retinal detachment, very similar to the first case I showed you, except that this was much more marked, and the patient had shaggy photoreceptors. There was indeed some fluid, both in the inner nuclear layer, but also in the outer nuclear layer. So there was some degree of macular edema, but this diffuse retinal separation caught our attention. On the examination of the fundus, again, you will see these multifocal yellow subretinal lesions. So these lesions, in addition with the subretinal fluid, made the patient be considered as, no, this is not VKH, but probably this is multifocal choroiditis, and the patient was unfortunately treated with immunosuppressants. but is this the correct diagnosis? And was this indeed just a pure bona fide classic macular edema? And do we need more tests? Well, let's look at this very carefully. If we look at the fundus picture, you'll see that you've got a lot of yellow lesions. And if you do an autofluorescence, which is a very, a non-invasive and very good examination, you'll see that these lesions, all of them here have a lot of hyperautofluorescence, corresponding to them. And there was a diffuse, hyperautofluorescence throughout the macula. And in the left eye, this was similar. You've got these yellowish, kind of vitelliform lesions in the under the retina, and they are tremendously hyperfluorescent on their own, hyperautofluorescent. So this was a very characteristic feature, and it permitted us to, redress the diagnosis and ask the patient to stop the immunosuppressants. Let's see this other case. This is a 12-year-old. She was referred for uveitis with macular edema, and she's had long-standing poor vision and was wearing hyperopic glasses. She had no night blindness, and her anterior segment was normal. But again, she also had very similar multifocal yellow lesions. And if you look at the OCT, you've got a notosensory retinal detachment that is diffuse. You have shaggy photoreceptors in both cases, and you have inner nuclear cysts, but no nerve fiber layer fluid, no plexiform, outer plexiform, and Henle fiber layer fluid. And again, very characteristic feature on autofluorescence with the multiple numerous hyperautofluorescent spots against a background of hyperautofluorescence around the macula. Same thing in the left eye, shaggy photoreceptors, and the retina swims or floats over the RPE, and a very characteristic feature. Now, this is a characteristic, I would practically say, pathognomonic fundus autofluorescence picture and OCT features. And so this is definitely not macular edema. Did we do more tests? Well, we did to satisfy ourselves. And in fact, yes, the patient did have the subnormal ERG, and we could have done an EOG. And if we had done an EOG, it would have showed the reduced Arden ratio, but we didn't do an EOG because in this case, it was so pneumonic. And of course, the patient was spared intravitreal injections and indications for inflammation. What is this case? What are these three cases? This is autosomal recessive bestrophinopathy. It is a retinal degeneration that is caused by homozygous or compound heterozygous mutation in BEST1 gene, and it has a very recognizable retinopathy, and it's diagnosed based on specific features. There is usually central visual loss, usually that starts early in the teenage years. It is recognized by the time the patient is a teenage or early 20s. There's a refractive hyperopia in almost all cases that are homozygous. There are widespread vitelliform lesions, extensive retinoschisis and subretinal fluid, shallow AC, high risk for glaucoma and angle closure, and reduced ERG and absent EOG rise. Here I'm just showing you a few cases of our collection where you can see these very characteristic hyperautofluorescent spots that correspond to these multiple multifocal vitelliform lesions. Sometimes when you don't have a lot of lesions, like nodular or pockets of vitelliform lesions, what you end up instead is having just this faint hyperautofluorescence, which is also abnormal. Here it is again, you don't have many vitelliform lesions here, but you do have this diffuse hyperautofluorescence in both cases. Now you can also have perimacular pigmentary changes that lead, make you think of either, retinal degeneration, or if you're, ill-informed of, you may consider that this is due to inflammation. And of course, the foveal schisis, which we've talked about with the subretinal fluid, with the detached retina that has shaggy photoreceptor. These are characteristic features. I would love for you to put this in your photographic memory. This is autosomal recessive Best disease. Here again is our case number 1, which had glaucoma. And I'm showing you again this hyperautofluorescence. She didn't have the yellow pigment, the yellow hyper vitelliform lesions, because probably they were all gone. But she did have this hyperautofluorescence that was very characteristic, and the areas where there was some RPE atrophy showing the presence of hyperautofluorescence. Her ERG was subnormal, and indeed her EOG was also abnormal. So the autosomal recessive best phenotype only manifests when the bestrophin protein activity drops below a functional threshold, and these appear to be, or they're required to be biallelic to function and cause the protein function to drop significantly. How do you recognize it? Well, I just went over what is needed. You need to take a good history. It's very important. It's important to recognize the hyperopia. Most patients will come in wearing these hyperopic glasses, so it's important to kind of pay attention to that. It is important to analyze the OCT correctly, recognize that the fluid is the inner nuclear layer, look carefully at the interdigitation zone, looking for subretinal fluid, and please evaluate all lines of the OCT and not just the central line. And of course, you must evaluate the entire fundus and evaluate the entire patient and ask a proper history, and you need to recognize the autofluorescence pattern. To permit the diagnosis, you can do either an EOG or you can do a BEST1 gene analysis. And it is important to recognize it because you would spare the patient anti-VEGF injections. You would avoid misdiagnosing them and treating them as uveitis. You can tell them that they are at risk of glaucoma and you need to monitor the angle because they are really at risk of glaucoma by the time they reach the age of 45 or 50. Most of them have some glaucoma and you need to do genetic counseling. Let's move on and to look at case 4. This is a 25-year-old healthy male. He was referred for refractory CME. A year prior to presentation, he had refractive lens extraction with PCI wells in both eyes and had no vision improvement. The patient unfortunately underwent 5 Avastin injections in each eye, 2 transeptal triamcinolone injections in each eye, and was even given Diamox. On the clinical examination, visual acuity in the right eye was 20/125, and in the left eye was 20/160. His anterior segment was unremarkable. He had a PCI wells with some posterior capsular opacification, and his fundus showed that he had a flat retina with a mildly dilated vessels and a kind of a crowded disc, and had blunted but thickened fovea. There's something in the chat. Sorry about that. Okay, so when we did a whole horizontal OCT, the line scan showed that there was a bulge in the inner retina with cystic cavities that were really in the inner nuclear layer. And there were also some cystoid cavities in the ganglion cell layers. And then we found that there were no fluid in the outer plexiform layer or the Henle fiber layer. So this put the diagnosis of CME into question. And we did a fluorescein angiogram, and yes, there was no leakage at all. So that also put the diagnosis of CME into question. The macular vertical line scan really gave us the clue. It showed us a U-shaped inner retinal fold, not a macular edema per se, with intrinsic cystic cavities in the outer nuclear layer and also in the ganglion cell layer, more superficially as seen here. So again, we knew the diagnosis. This is posterior microthalamus, where the papular macular fold, which is characteristic of this condition, with the cystoid changes, with the cystic changes, made the referring ophthalmologist think that this is macular edema. The patient, we confirmed that this is microthalamus by doing an A-scan ultrasonography, which showed that the patient had short axial length, approximately 16 millimeters of axial length. The corneal diameters were normal. Okay, and they had a normal looking anterior segment, so the patient, could have fooled the initial doctor. Of course, we recommended no further injections, and 2 and 3 years later, the patient's picture is absolutely stable. So what is posterior microthalamus? It's an ocular phenotype that is due to recessive autosomal recessive mutations in the PRS-S55 gene and the MFRP gene. It causes high hyperopia, short axial length, usually less than 18, and more typically like 15 or 16 millimeters, a normal or anterior segment of subnormal dimensions that you can't really tell by just looking at it. You have a posterior short posterior segment and a horizontal papular macular fold. And if you do keratometry, practically all eyes have very steep corneas. You can have additional signs such as these full optic nerves and the congestion of the veins. You can have also subretinal exudates because these patients have very thick sclera, and their uveoscleral outflow is kind of compromised, so that they're easily prone to uveal effusion and choroidal folds. And recognize this condition is not always easy. Patients can have deep-set eyes, but the eyes don't appear normal because the anterior segment is, almost of normal dimensions, but it's really the papillomacular fold that is the hallmark diagnostic feature. And these folds can come in all shapes and forms that you can see. They can have thick folds, moderate folds, tiny folds, even just superficial wrinkles. And of course, if you're uninformed, then you can think that this is macular edema. And more so, you can be thrown off if you have these cysts in the papillomacular fold, thinking that this could represent macular edema. The vertical scan is very helpful because it can show you all kinds of shapes of these folds and put them into perspective. You can find that you can have these very high folds versus the low dome-shaped folds, or even the wrinkles. And how do you differentiate them from macular edema? Well, you have to look carefully at the OCT. In the PMF is actually a partial thickness fold, retinal fold. It is not a thickening, a diffuse thickening of the macula. It spares the retinal pigment epithelium, the photoreceptors, the ellipsoid zone, the external limiting membrane, and the outer nuclear layer. These are not involved in the fold, absolutely not. Here they are, not involved in the fold. But it includes, this fold includes the nerve fiber layer, which is the Henle fiber layer, the OPL, and the rest of the inner retina, as we can see here. And of course, you have preservation of the retinal anatomy, both within the fold and beyond it. Now, cysts do exist in these folds. 50% of these folds have intranuclear cysts, which are visible on OCT, but you cannot detect them clinically, like as we can see here. And about 30% will have ganglion cell layer cysts, which are visible clinically, as we can see here. And those are obviously misdiagnosed as CME. Here they are. They're more superficial and therefore visible on the clinical exam. But again, remember, there are no cysts in the outer retina or the plexiform layer. So this is not cystoid edema. And if you do a fluorescein angiogram, these folds do not leak. Ultrasound is necessary to establish the diagnosis by showing the short axial length. And it is very important to recognize posterior macular thalamus because it is confused as CME, and patients have undergone non-necessary intravitreal injections, and therefore monitoring is needed. Sorry. So you have to recognize them, and monitoring is needed in patients who have posterior macular thalamus because they have, as the lens grows and becomes bigger, the angle becomes shallower, and therefore they are again also at risk of angle-closure glaucoma and of uveal effusion. Let's move on to case number 5. This is the 33-year-old male. He had no known illnesses, and he complained of decreased vision for the past 2 weeks in the left eye. His visual acuity was relatively okay in the right eye, 20/40, but it was 2300 in the left eye, and the right fundus was, written off as unremarkable. The left fundus had hemorrhages in, the superior part of the retina, obvious what looked like a congestion of the optic nerve and the macula, and the diagnosis of hemiretinal vein occlusion is made. And the fluorescein angiogram did indeed support the diagnosis of hemiretinal vein occlusion, and indeed on an OCT you could see the retinal thickening and the presence of macular edema with the presence of fluid in the outer plexiform layer. So intravitreal bevacizumab was given. A month later, the patient did much better. He was very happy. But when we looked at the OCT, we realized that there were some little bit of fluid remaining. And so we were questioning, is this residual macular edema? But when we look carefully, where is the fluid located? The fluid is located in the inner nuclear layer and within inner nuclear cysts. However, what we're seeing is a retinal fold that is sparing the outer nuclear layer. So here we are thinking, did we miss anything? And indeed, when we went back to the OCT, we realized that there were also inner nuclear cysts in this area. And what we did is we did an axial length examination by ultrasound, and we discovered that this patient also had posterior macular thalamus. Luckily, with the injection, he did not undergo, get an angle closure glaucoma case, or a high, pressure, because the vitreous cavities in these people is very small. So if you inject a full dose of of Avastin or, steroids, you can induce a very, very high pressure and central artery occlusion. But this patient was spared this complication. Looking back again at the right eye, looking a little bit more carefully, we actually recognize that the patient did not have a normal OCT. He had a shallow dome-shaped fold that, partial thickness fold that involved the inner retina, but that spared the RPE, and this was primarily seen on the vertical OCT. So a high index of suspicion is really needed for the diagnosis of posterior microphthalmos. They are among us. You will see these patients invariably. We have this is an autosomal recessive disease, and you will see more often than not people coming in with posterior microphthalmos that may not be recognized. So please do not make the mistake of considering this macular edema. Get a scan, recognize where the fluid is located, and if you need, get a vertical scan, which should be part of the protocol, and it will indeed show you and demonstrate the fold much better. So a high index of suspicion is needed. So please put this in your mind and remember posterior microphthalmos. Here's my ghost. Case number 6. This is a 20-year-old male. He was referred for retinitis pigmentosa with macular edema. Before coming to KKISH, he's had 1 intravitreal injection of anti-VEGF in the right eye, 3 intravitreal injections in the left eye, and even an dexamethasone implant in the left eye. He's been complaining of progressive decrease of vision since the age of 19 years after he had a road traffic accident. But when we dug in a little bit more, we noticed that we questioned, and he did have night vision problems. His parents are first cousins, and he has 6 siblings, which don't have any, ophthalmological problems. And his visual acuity in the right eye was 20/80, and in the left eye was 8/200, and his anterior segments were normal. When we did a picture, this is what we saw. We saw definitely some pigmentation in the mid-periphery and in the near periphery, but what caught the attention was that there were no dome spicules. These were clumps. These were deep hyperpigmented retinal pigmented clumps. On an autofluorescence, which we do routinely on cases that we are suspecting of having retinal degeneration, he did have a hyperautofluorescent ring, but he had this peculiar hypoautofluorescent larger ring around the macula and in the nasal periphery. And on the OCT in the right eye, he did not have any macular edema, but had some vitreous debris. In the left eye, the changes were very, very similar, again with nodular RPE clumps around the arcades and nasally, the same feature on the autofluorescence, but of course, in this case, he had both outer plexiform layer, fluid, suggesting that there was some element of macular edema, but also inner nuclear cysts. But on the en face image, you can see this pockmarked appearance, suggesting that this is primarily aschisis rather than edema. So is this RP, and is this macular edema? Let's look at the second case. This is a 21-year-old female referred for retinitis pigmentosa with macular edema. She had night blindness since the age of 7 years, and her parents are first cousins. Her features were very similar to the previous case. She has characteristic perimacular pigment clumps and RPE changes, and has these characteristic hypopigmented autofluorescence areas around the arcades and nasally. The macular OCT showed a tremendous amount of thickening, as you can see by the maps right here, and showed the schitic changes. But let's look more carefully at the retinal scan in the right eye, and where you can see on the raster scan, going up to down all the way here, that are splits in the inner nuclear layer, and some. I'm sorry, that there are splits here, that they're in inner nuclear cysts that you can see throughout the macula all over the place, but there are splits also in the outer plexiform layer, and they have these ragged, distorted edges. There are even retinal atrophies and outer retinal holes, which is a little bit unlikely to get outer retinal hole immediately with any macular edema. So is this RP? Well, no, this is enhanced as syndrome. It's an autosomal recessive degeneration caused primarily by biallelic mutations in the NR2E3 gene. This gene controls the fate of the photoreceptors, and where you have many more cones, short wavelength cones than normal L and M cones rods, and therefore you have a hyperfunction of the shortwave cones on the ERG, giving a pathognomonic ERG. Clinically, people have hyperopia, and they have nyctalopia, or night blindness, and they have these very peculiar and clumped pigmentations around the macular arcades, and they often have a macular schisis. So this case, this enhanced syndrome is very, very commonly mistaken for RP. But remember, these are coarse pigment epithelial clumps, coarse clumps of pigment, and not bone spicules. And there could be a very variable. They could be big and nodular, such as we see in this case, or they can be very discrete, okay, small and focal, such as we see in this case. They can also be replaced, or in addition to having, salt and pepper changes in the fundus, and sometimes you even see fleck-like drusen. The foveal schisis can be absent or can be very small, resembling a CME, can be broad and shallow, and can be dome-shaped. But again, there's always a presence of fluid in the inner nuclear layer. And oftentimes you will see vitreous changes, which sometimes are seen only on OCT as presence of debris and veils. And these have not uncommonly been confused with vitritis. And I've seen patients that have been given systemic and intravitreal steroids for the presence of these, pigmentary changes in the fundus, some kind of a macular edema, pseudomacular edema, I would say, and a little bit of debris and cells in the vitreous, and the patient immediately gets an injection. It's really unfortunate. Submacular fibrosis also exists in these patients of various types, and this can also be confused with inflammation, and the patients be given intravitreal steroids. So basically, the diagnosis is based on a pathognomonic ERG that shows a non-detectable scotopic ERG and a very similar waveform in the scotopic and the photopic condition, which is a delayed and simplified waveform, and amplitudes in the flicker, photopic flicker responses that are lower in amplitude than the single flash photopic ERG. It is important to recognize enhanced syndrome because basically you need to avoid that patients have inappropriate anti-VEGF therapy or steroids injection, and avoid also when they have this edema and this fibrosis to consider them as inflammatory cases and have them undergo investigations and treatment. And it's important to do the correct diagnosis and screen and counsel the patients. So how do you do that? You must analyze the OCT correctly. You must know the difference between clumped retinopathy and bone-like spicules, and you can get an ERG, which would be pathognomonic. This is now let's move on to case number 8, which is a 13-year-old male referred for CME in both eyes. He's had stable vision in the right eye, but that it was past medical history was unremarkable. His brother had amblyopia, and he had no nystagmus and no strabismus, and vitreous was normal. When we did the pictures, we showed that he had practically a normal retina apart from this large peripheral schisis, and he had a cystoid maculopathy in both eyes. But again, is this macular edema? When you look at the cystoid maculopathy, you realize that this is primarily located in the inner nuclear layer and not in the outer plexiform layer. There are hardly any fluid in the outer plexiform layer. So this is diffuse splitting. This is not macular edema. There is also no leakage on the late angiograms. And here's a big enlarged photo that shows you this cartwheel pattern of the fovea, which is very typical. The patient had an electronegative ERG, and his genetic analysis confirmed the mutation in the retinoschisis gene. So this is juvenile retinoschisis, not to be confused with macular edema, not to be treated with anti-VEGF steroid injections or even systemic steroids. There is no effective treatment up to now, as far as I know. Case number 9. Case number 9 is a 52-year-old female referred for, is this macular edema? She has been seeing poorly, reading poorly for the past 6 years, but she says that this poor vision started after she has been looking at the sun. She was sun gazing. There's no history of day or night blindness, no systemic illness, and unremarkable family history. And her visual acuity was around 20/50, 21/60. The fovea in the right eye practically looked normal, but on the OCT, she had this outer lamellar hole with adjacent atrophy and the ellipsoid zone. So could this be solar maculopathy? Indeed, it could. Cone dysfunction, unlikely because she didn't have any day problems, day vision problem. Could this be macular telangiectasia type 2? And the fluorescein angiogram confirmed that this is probably the case with this staining, this faint staining that you see in the late angiogram, just in the juxtatemporal area. There was also decreased normal foveal hypoautofluorescence. The left eye had much more marked features with grain of the perifoveal area, parafoveal hyperfluorescent staining, and again decreased normal foveal hypoautofluorescence. And the OCT showed typical features of MACTEL2 with a tiny ILM drape and outer retinal holes and adjacent atrophy. So this is a characteristic OCT. I also want you to put this picture in your photographic memory. This is MACTEL2 until proven otherwise. What is MACTEL2? It's called also perifoveal telangiectasia. It's the most common form of telangiectasia, of parafoveal telangiectasia, that is. It is acquired, not congenital, and affects people around the age of 50, males just as females, and it's bilateral but could be asymmetric, and the telangiectasia is hardly visible, and it goes through 5 stages. In the first stage, you can hardly see anything, but in the fluorescein, you will see some faint staining of the parafoveal edge. In stage 2, you will see some grayishness around the foveola with more staining around on the fluorescein angiogram. And in stage 3, that's when patients start to really have reduced vision. You'll start to see these right-angled venules, sometimes crystals, and a lot more staining around the fovea, but no pooling on OCT, no pooling in the outer plexiform layer on OCT. Stage 4 is characterized by the presence of pigment that comes in usually temporally, but can actually be even on the nasal side of the foveola. And this is also very characteristic. Sometimes all what you see in a patient is 2 spots of pigment, in 1 spot of pigment in each eye, temporal, the fovea. That makes your diagnosis. That is MACTEL2 until proven otherwise. Here's one of my patients who I've followed, and you can see the progression from the grayishness, the right angle venule, and then the macular pigment temporally. The OCT is really characteristic. There is no thickening, there is no fluid in the OPL, there is foveal atrophy, and there are these, the loss of tissue within the fovea, both in the outer retina and throughout the retina as well, and this characteristic ILM drape, and the center part of the map is actually atrophic. You can see that there is very low thickness. So the vision loss is due to atrophy and not thickness. MACTEL can be compromised with subretinal neovascularization, where the telangiectatic vessels move under the retina and start to proliferate and then connect with the choroid, giving you a kind of a wrap, retinal angiomatous proliferation type of CNV. This will require treatment with anti-VEGF. So anti-VEGF is not appropriate for MACTEL2. However, if you have a stage 5 in which you can definitely distinguish the subretinal neovascularization from the rest of the telangiectasia, in that case, yes, you can give the anti-VEGF. Now let's look at this case. This is a 45-year-old male. He did not have any macular illness. He's had 6 months ago cataract surgery, but has been complaining of poor vision that happened 2 months ago. His visual acuity is 20/40 in both eyes, and his anterior segment is unremarkable. And what we see on the OCT and on the fluorescein angiogram, we see telangiectasia and leakage of this telangiectasia. And on the OCT, there is definite fluid in the outer plexiform layer. So yes, there is macular edema. There is subretinal fluid and perhaps a little bit of internuclear cyst. But is this pseudophakic macular edema? Is this a BRVO that can obviously give also features with telangiectasia in the macula? Is this MACTEL2? Well, no, this is aneurysmal telangiectasia, or MACTEL1, which is a congenital abnormality or a developmental abnormality that affects primarily males, and it's usually unilateral, and is characterized by visible telangiectasia. It's associated with macular edema. The telangiectasia are often straddle the horizontal raphe, and it can cause cystic pooling or non-cystic pooling in the fluorescein angiogram. And it's considered as a mini-Coats disease because it can be associated with a peripheral telangiectasia as well. Here you can see the mid-peripheral vascular changes and the cystic dye pooling. The macular edema is a true macular edema, as I told you, and you can see here in this case, this is the same case here. This case actually had only one little cyst, but the cyst was in the OPL. It was in the outer plexiform layer. It was not in the inner nuclear layer. So this was true macular edema. There is no involvement in the outer nuclear layer, or the ellipsoid zone, such as we see in the Mactel 2. I'm going to go skip through this and basically tell you that in this case, you can give anti-VEGF, although this has not been proven. And lastly, I'm going to go very quickly through these last cases, which just to illustrate how macular edema can be misdiagnosed or missed if you do a hurried fundus examination or a cursory analysis of the OCT. And then they will illustrate the value of analyzing the entire raster macular scan. This is a case where there was one little tiny cyst, and the vitreous seemed, unattached, basically separated from here. But if you look carefully, slightly lower down, you can see that there is some vitreomacular adhesion, and what this patient had was vitreomacular traction. So if you had looked only at this, you would probably think, oh, this is just macular edema. But in fact, if you look through the entire scan, sometimes you see adhesions of the vitreous face telling you that there's a mechanical cause for this macular edema, which you need to consider. Here's another case in which there's indeed macular edema. You can see fluid in the RPL, a little bit of fluid in the inner nuclear layer, even subretinal fluid. But this patient was not fixating properly. And when we looked at the entire scan, what we recognized is that he had a tiny macular hole. And of course, you will not give anti-VEGF for something like this. This is something that would require surgery. So this, again, stresses the importance of looking at the entire macular scan and not just one scan, particularly in patients who cannot fixate very well. So it's very important to look at that. And here's the last case. This is a patient who had fluid in the macula. He had fluid in the nerve fiber layer, the Henle fiber layer, the LPL, had even inner nuclear cyst and even had subretinal fluid. And of course, you would consider that this is macular edema. This was the raster scan, the central line on the raster scan. But here, when you do a horizontal, full, thick, the horizontal line scan, which is usually longer, and going through the pathology, you will see that this macular edema actually connects to the optic nerve right there. And you can see it right there. There is a pathology that has created this macular edema, which was missed on the scan, the raster scan. Here it is again. And here is the flesh, the arrow going through the pathology. What is this? Of course, this is optic nerve head pit. I did not show you this. Actually, the doctor did recognize this after looking at the eye. But had you been looking only at the OCT to make a diagnosis, you would have missed this and considered that this is macular edema. Well, this is an optic nerve pit maculopathy, where it's important to look at the all scans and even the SLO image. And here's another case in which you have definite fluid in the OPL and the nerve fiber layer. Here it is again on the central line on the raster scan. You can see that there's fluid in the OPL, okay, in the outer plexiform layer, so definitely macular edema. But when you extend the scan, you can see that it's also connecting to the optic nerve area. And what happened here is that the vertical scan here missed this conduit, and this scan missed this conduit as much as well. But if you go through the entire scan, you may pick it up and realize that this is an optic nerve head pit, a tiny pit in this case, and that's the importance of looking at the entire scans and the SLO image. So in conclusion, a careful fundus examination and history taken combined with a correct macular OCT analysis are crucial before labeling a case as macular edema, or worse, administering intravitreal anti-VEGF therapy or systemic anti-inflammatory therapy. Now, diligence in interpreting the OCT means you know the anatomy, you recognize the location of the macular fluid in the OPL versus in the inner nuclear layer. You qualitatively assess all the lines of the scan, not just the central lines, and you do not rely on an OCT map to diagnose macular edema. Now, autosomal bestrophinopathy, enhanced Escon syndrome, posterior microphthalmos, MACTEL 1 and 2 particularly, and all these other pathologies that are presented today are not uncommon, and you're going to encounter them. And they're not uncommon because they're also mostly hereditary and autosomal recessive, and this is very common in our country. So you're going to see these more often than in other places. And they must be recognized because patients are frequently misdiagnosed, and many are subjected to unnecessary investigations and invasive intravitreal injections. So it is my hope today that this presentation would increase the recognition of these conditions and spare our patients unnecessary burden and risks. And with this, I thank you very much.
Thank you so much, Dr. Sawsan, for this outstanding presentation. The images really add so much to the cases that you're presenting. Like you very well said, we would think that these are uncommon pathologies, but in our setting, specifically in our population, they're so much more frequent than we expect. Don't you agree?
I agree perfectly. Perfectly. Yeah. And these cases are referred to us because, doctors have tried different treatments. And when they come to us, we recognize that, the diagnosis was all wrong. Yes.
So that's precisely a red flag, something we have to take into account. A patient that's been treated within our institution or referred from outside, if it's not responding to conventional treatment, then something else is going on. We need to, like you said, study the entire raster and study the fundus as well. And we can't limit ourselves to becoming OCT specialists, right?
I like that.
Yeah.
I like that term, yes. Yeah.
I think my grand round a few weeks ago about the crunch phenomenon was also, it had a similar take-home message that don't treat the OCT, treat the fundus. There's other things we need to be looking at. But this is outstanding.
Thank
you. In regards to the tractional schisis that we see so much in diabetic patients, either from epiretinal membranes or from the actual vitreous traction, do you have a specific algorithm you like to treat them with? Because some of them will respond, the edema, to the anti-VEGF, but when would you consider saying, now this needs a surgical intervention and not an anti-VEGF approach?
Very nice question.
Because I see that they keep treating and treating for months, and
yes. I would, and it's actually a question, there's a debate because the surgeons will tell you it's better to go in early, and do a vitrectomy early so that you can gain the maximum vision, not wait too long. And then there are other people who tell you, well, given anti-VEGF, maybe the adhesions that you're seeing from the epiretinal membrane or the vitreous are incidental and not causing like they're bystanding phenomena, not causing the macular edema. So if a patient comes to me and has never had any anti-VEGF injections, and I know that this is a vascular disease and there's obviously diabetic edema there, it's not just, some kind of a schisis or something else, then I would try an anti-VEGF, perhaps 1 or 2 or even 3 injections. If I see improvement, I will continue. But once I, on a monthly basis, I do follow these patients. Once I see that they're no longer improving and that they have, the persistent traction that causes this macular thickening, I would refer them. So I would say after 3 injections, you should know, probably 3 or 4 injections maximum, you should know, yeah. And then refer the patient, yeah.
Absolutely. Surgery. And there's so many more questions that we could go into with all these examples that you've given. Unfortunately, I believe Professor Liu has a lecture in the auditorium. Yeah. It's going to be physical right now, so if everyone can go down and join them. And I was asked to convey the message that next grand round is going to be physical in the auditorium as well. I believe it's not going to be held by Zoom. So it seems like we're getting back to normal.
Yeah, nice, interesting, and exciting.
Thank you so much for your presentation, Dr. Sawsan.
You're more than welcome. We have a quiz after the lecture of Professor Liu as well. Okay, thank you. Take care.
Thank you.
Thanks.